Hey guys, how are you? This is your cardiovascular guru, Dr. Akshay Sharma. Today we will be taking up an important topic and a high yield topic, acute rheumatic fever. We have divided this topic into three videos. First, introduction and pathogenesis of rheumatic fever. Second, pathology, microscopic as well as macroscopic. And the final one is the diagnosis including the Jones criteria. So let's kick off with the first video, introduction and pathogenesis of acute rheumatic fever. For preparing this lecture, I have gone through Harrison, Robbins, Kaplan notes, Pathos, and the first aid for USMLE. Acute rheumatic fever is a multi-system disease. It involves many systems, not only the heart, but involves many systems. It is an autoimmune reaction. Point number 2, autoimmune. First number point, multi-system. Second, it is an autoimmune reaction, and a reaction to what? To the infection of group A Streptococcus. So 3 points to remember: multi-system disease, autoimmune reaction, and reaction to what? Reaction to the infection to group A Streptococcus. All the manifestations of acute rheumatic fever except the valvular heart disease part resolve spontaneously. The valves are affected in a long run, so they tend to deteriorate over a period of time. The disease, the valvular pathology, does not subside by itself. All other manifestations tend to resolve spontaneously. So one-liners: most common cause of acquired heart disease. Rheumatic fever is the most common cause of acquired heart disease in children of developing countries, the third world countries like our country or the Indian subcontinent and the African continent as well. It is mainly a disease of children 5 to 14 years of age, although the prevalence is peaks at 25 to 40 years, but the primary infection, the primary pathology starts at the age of 5 to 14 years, mainly a disease of children 5 to 14 years. Older adolescents and young adults, they tend not to have initial episodes. They have recurrent episodes. So recurrent episodes are common in older adolescent and young adults, and in this age group, the initial episode is rare. The initial episode is usually at the age of 5 to 14 years. Acute rheumatic fever, male and female incidence is same. But rheumatic heart disease, the females are affected more than males. So acute rheumatic fever, male is equal to female, and in rheumatic heart disease, RHD, the females, the prevalence in the female population is more than the male population. Now, for studying the pathogenesis, we have to see the three aspects. First, what is the organism involved? So what is the special about the organism? How does it trigger an immunological response in the host, that is the immunological factors, and what type of host? Is there any special thing about the host which is involved? So we have got organism factors, host factors, and finally the immune factors. So what is the organism involved? Organism involved is a group A beta hemolytic streptococci. It is a streptococci, it is beta hemolytic, and it is group A. Any other special thing? With M serotype, which is called as rheumatogenic motifs. So M serotype of group A beta hemolytic streptococci. The M serotypes are 1, 3, 5, 6, 14, 19, 24, 27 and 29. Other M serotypes can also be involved, but these are the most commonly involved. Till some time back, it was believed that the beta hemolytic streptococci infection, especially the throat infection, causes the acute rheumatic fever. But as it is mentioned in the Harrison, the latest edition, the 21st edition, that there is a significant role of streptococcal skin infection as well in the causation of the acute rheumatic fever. So significant role of streptococcal skin infection in addition to the streptococcal throat infection. Now the host factor, what is special about the host? Only 3 to 6% population is susceptible. Not everybody is susceptible to acute rheumatic fever. It is not like everybody who has a streptococcal throat infection lands up in having acute rheumatic fever and valvular heart damage. So this is only 3 to 6% of the population susceptible to the acute rheumatic fever. Familial clustering is seen. It runs in the family. That is, many members of the same family can be affected. There are certain HLA class 2 alleles that can be susceptible and some can be protective. The susceptible ones are DR4 and DR7. The ones that are protective for acute rheumatic fever are DR5, 6, 51, 52 and DQ. Now let's see the immunological response, the immunological factors of acute rheumatic fever. The key point, the key word that you have to remember in immunological aspect of rheumatic fever is molecular mimicry. This is the most important word. You should be knowing the mechanism of immunological damage of acute rheumatic fever is molecular mimicry. So what is molecular mimicry? There is some molecule that mimics some other thing. There is an immune response. There is an infection of streptococcus. The body mounts an immune response that is targeted against what? Targeted against streptococcal antigens. But it recognizes a human tissue as well. That immune response, in addition to the streptococcal antigen, recognizes a human tissue as well, and that tissue is myosin. So this is what we call molecular mimicry. What are the streptococcal antigens involved in this? What are the streptococcal antigens against which the immune response is mounted? These antigens are, one is protein antigen, that is the M protein, and the other is the carbohydrate antigen, that is the N-acetyl glucosamine. Two streptococcal antigens, M protein and N-acetyl glucosamine. The immune response is against these two, but the immune response also recognizes the human tissue, that is the myosin. Further, in the immune factors, this all is a type 2 hypersensitivity. This type 2 hypersensitivity which causes two things. One is antibody binding. Antibody binding causes complement activation and recruitment of neutrophils and macrophages. The other is stimulation of T cells, which causes cytokine production. And finally, macrophage activation. This all the immune response, antibody binding, stimulation of T cells, cytokine production, macrophage, mitophage, they ultimately cause heart tissue damage. So immunological response to streptococcal antigen, finally causes heart tissue damage. See, first slide we saw that rheumatic fever is a multi-organ, multi-system disease. So we have so many features of acute rheumatic fever. One is polyarthritis, the other one is carditis. These are two the most common. Almost all the patients, up to 75% of the patients will have polyarthritis, involvement of joints, carditis, involvement of the heart. 2 to 30 Sydenham chorea, and skin manifestations are more of academic value. They are seen in less than 5%. So the most common are polyarthritis and carditis. The least common are the skin manifestation. There is always a latent period before the manifestations occur after the streptococcal throat infection. This is all around 1 to 5 weeks. It is not like the infection occurred today and the acute rheumatic fever will start from tomorrow or day after. So it will take around 1 to 5 weeks for the manifestations to come. Chorea and indolent carditis can happen up to 6 months as well. preceding infection, an obvious throat infection is usually missing. The parents or the child, is not able to give a strong positive history of a throat infection. So mostly these are subclinical. So let's see what is the natural course of the disease of acute rheumatic fever. There is a streptococcal upper respiratory tract infection causing acute rheumatic fever after a latent period of 1 to 5 weeks. This may directly lead to rheumatic heart disease, or the initial episode may subside and a recurrent acute rheumatic fever episode may come up later in the date, which finally causes rheumatic heart disease. Now, the rheumatic heart disease, long-standing rheumatic heart disease, can cause heart failure or endocarditis and stroke, and the ultimate outcome is either a surgery, which I usually do very frequently, or disability or death. So in this video, what we saw, we got ourselves acquainted to rheumatic fever. We went through certain one-liners. We saw the host factors, the organism factors, and the immunological response that the body mounts against streptococcal antigen and unfortunately recognizes our own antigen, that is the myosin. So this was the first video. The second video will follow soon, in which we will discuss the pathological aspects, both microscopic and the macroscopic aspects of acute rheumatic fever.